So and thanks about for this kind arrangement. When they approached me with this subject, I asked what I could contribute to this meeting, and they said they want to know something new. Frankly, there is nothing new. I think we will revise whatever we may know, and we may stumble upon something new in that process. So we get a lot of patients from our colleagues for various problems, and here are some problems related to pregnancy. I'm not talking about gynecological conditions because it is such a huge chapter otherwise. So we get a lot of patients with pregnancy and abnormal liver function test, particularly raised transaminases. We get patients who are detected to be hepatitis B positive for the first time, or they have history of hepatitis B being positive, hepatitis C. And then now we have a lot of IVF going on, and there are a lot of patients with abnormal liver function test. We do get patients with pregnancy and portal hypertension. In fact, we recently had a patient in our labor room at Max Hospital with advanced portal hypertension and pregnancy, and it was a nightmare. I don't know what ultimately happened because she was an EWS patient. So she was operated, she delivered, but subsequently I do not know about her course. There may be occasions when we have to do endoscopy in patients who are pregnant. Gallstones are very common. In fact, a lot of pregnant mothers develop for the first time. And fatty liver disease is a disease of this centenary, which is going to trouble us in future more and more, and we will see a lot of repercussions of fatty liver disease in pregnancy. So I should not overstep my time. I'm going to present few cases. Don't look at the slides. Let us talk to each other. Slides are for me to remember my content. So this is a 32-year-old lady, 18-week pregnancy, primary, came with itching for 2 weeks, no history of previous liver disease, no history of any family history of any liver disease, CBC normal, LFT, ALT, ST 112, alkaline phosphatase normal, bile acid was 40 micromole, hepatitis B and C are negative. This is the data. INR is normal, ultrasound is normal, normal liver. So, what are the possibilities?
Hepatic cholestatic.
Why intrahepatic cholestatic?
99% of the time is high during pregnancy.
At 18 weeks, it may not be very high. Right?
Other causes are bile acid is going towards the higher side.
Yeah, so it represents some amount of cholestasis. If it is more than 10 micromole, it means it is cholestatic variety. You are right. So the abnormal transaminases may be because of diseases limited to pregnancy, that the disease initiated in pregnant state, or it may be unrelated to pregnancy. So we must not forget diseases unrelated to pregnancy. Out of 10 cases of ISCP, which so-called ISCP, which I receive from my own hospital, 3 are either autoimmune hepatitis or severe fatty liver disease. Don't forget about fatty liver disease. All of us are obese, all of us have extra weight, all of us are not exercising, all of us are, I will say, have some amount of hepatic fibrosis as we age. So fatty liver disease is there in everybody. So it may be responsible for raised aminotransferases. So in this patient, we thought of ISCP, and we excluded other reasons like by doing anti-nuclear antibody, anti-smooth muscle antibody, and other investigations. And we ultimately diagnosed intrahepatic cholestasis of pregnancy. So ISCP is a very common disorder. Now what is our goal? How do we treat this patient? So drug-induced liver disease is very common and often ignored. Agreed.
And hepatitis A and E,
yeah. A and E occur generally in acute setting. You will have enzymes in hundreds and thousands. and patient will have acute loss of appetite as well. So, how do we treat? What are the goals of treatment? See, the goals of treatment is to make the mother comfortable, because itching is the most important symptom. And also ISCP is associated with adverse outcomes. So we want to save the child. How do we make mother more comfortable? By giving, which is the drug of choice? UDC. Let's call it UD Live today. Right? Okay. So the initial starting dose is usual 300 milligram twice a day for a normal weight lady. But if it does not help, how will we know it is not helping? Itching is not improving, and bile salts are not coming down. At what interval do we ask our patient to come back for bile salt analysis once again? After 2 to 3 weeks, right? So if this UDCA is not working in 2 to 3 weeks, then we have to step up the dose. How much we can step up? 450 milligram twice a day is the usual next step, and you can go up to 20 to 21 milligram per kg body weight. Although at that dose, many patients will have diarrhea and nausea. Absolutely, yes. In this particular case, the bile acids are on a much higher side. 40 is the cutoff limit for. So, UDCA not only helps in bringing down liver enzymes and pruritus, it also helps in reduction in bile acid levels, decreased incidence of premature death, fetal distress, respiratory distress syndrome, and need for neonatal intensive ICU care. So that answers your question. We have to continue it till term. Now, when UDCA is also not working, there are many patients who have troublesome itching, and then what we can do. So this is something new which you can consider new knowledge, which is not routinely done. We can use rifampicin, the drug which we use for antitubercular treatment, 150 to 300 milligram per day. Okay, I have never used it. Why I have not used it? Number one, that I do not want to introduce any medication in mind of the lady. It can be teratogenic. Number one. And number two, most of my patients do not come to me with for regular follow-up. They will come, then they will disappear for 3 weeks, 4 weeks, then they will come again. So unless you have a patient who is following you very closely, you cannot give drugs like these.
He's sharing his experience that as a senior gastroenterologist, he has not used it as yet.
No.
उसको बता रहा है कि आप ही कम use करोगे.
So I have used cholestyramine in many patients, which is very well accepted, and this is in aridin. You can give it with any fluid, juice, soup, any cold drink with 4 grams 3 times a day before meals. There is some mention of S-adenosyl L-methionine, which is Heptral or Serosam. This is in intravenous form. It also helps ISCP. So this was the new information. Okay. If the bile acid level is more than 100, you go for early delivery. All societies suggest that delivery should be done or postponed up to 36 to 37 weeks as much as possible. Okay, so there is nothing new. Case number 2. Almost similar profile of patient, 42-year-old, 18-week, hepatitis B surface antigen is positive. The patient does not know that she was already positive or she has acquired hepatitis B now. There is nothing to suggest that she has acquired hepatitis B currently. Ultrasound does not show any evidence of previous chronic liver disease. So possibilities in this particular case are quite apparent: hepatitis B related liver disease. E antigen, which is a marker of infectivity, replication, is positive, E antibody is negative, and HBV DNA is 56,000 international units per ml. If it is more than 20,000, it is it's significant. If E antigen is negative, then the significance is acquired at 2,000 only. But according to recent WHO criteria, I am not talking of pregnant patients. In otherwise, all patients with hepatitis B with detectable HBV DNA should be treated, because the goal is to eliminate hepatitis B from the earth. So what is the aim of treating this patient? Again, treatment of mother and prevention of mother to child transmission. These are two aims. How do we treat the mother? If you detect hepatitis B before pregnancy, you can counsel your patient not to get pregnant till further assessment is made and she has been adequately treated. If that is missing and patient has already become pregnant and has come to you, you may, and if disease is mild, no treatment is required up to second trimester or third trimester. Revisit the patient in second and third trimester. See, look at the liver disease. If liver disease is child's A, mild elevation of enzymes, as in this case, no evidence of active liver disease, don't treat the mother, but you have to prevent MTCT. So we will do HBV DNA, especially in the third trimester of pregnancy, and we can give antiviral prophylaxis beginning third trimester of pregnancy, 28 weeks. So what is new in this new knowledge which I have acquired while preparing for this talk? Maternal treatment: avoid category C and D medications. Avoid medications in first trimester, of course. Start medication based on liver status. Postpone medication to second or third trimester. This we have already discussed. What is the choice of therapy? Today it is tenofovir disoxyribonucleic fumarate, TDF, and telbivudine. Telbivudine is now out, so you have either TDF or TAF. Tenofovir TAF, I'm just forgetting the full name, TA for and using it day and night, but this anomia. So entecavir is another drug for hepatitis B, not to be used. Adifovir, lamivudine, you will find in some corner in Delhi also people using these medications, but please don't use them. You can use TDF only, okay? PEG interferons have been used for treatment of hepatitis B. No role in pregnancy, they are contraindicated. So, yeah, the full name of this medication was tenofovir alafenamide. Okay, 25 milligram once a day is safe and effective medication. Not much literature is available, maybe about handful of papers, but now it is definitely it is going to come in guidelines that this is superior to TDF. TAF is superior to TDF in pregnancy management of hepatitis B, because it does not cause osteopenia and does not cause renal problems as TDF and entecavir can. Okay, so in future TAF will replace TDF. Case number 3. Now this is interesting because there is a lot of new things to learn. This is again some same kind of patient, 28-week pregnancy, hepatitis C antibody positive. This is a very common situation, and there are surgeons and gynecologists and obstetricians who are afraid of dealing with hepatitis C positive patients. So I think this is because of lack of knowledge. If you take proper precautions, so people, still we get references, please make it negative and then we will operate or something. So possibility in this case is hepatitis C related liver disease, and HCV RNA is 6000 IU per ml. Remember, in hepatitis B, we knew that 2000 or 20,000 are cutoff limits. In hepatitis C, there is no cutoff limit. If you have even 100 international unit, you are bound to treat this patient. What are the considerations? All women, there was some reference that for TORCH and other, there should be no screening. But for hepatitis B and C, universal screening is advised all over. So all pregnant patients with or without history of any hepatitis or liver disease must be screened for hepatitis B and C, because if mother is found to be positive, at least mother can be treated later on after delivery. If antibody is positive, get HCV RNA quantitative done. See, there are two kinds of tests, qualitative and quantitative. Lot of people go for qualitative. I don't know why. There is no role. Both are equally expensive or equally cheap. So go for quantitative. There are certain procedures which were being described in Dr. Seema's talk also, Dr. Renu's talk also, that you have to avoid invasive prenatal diagnostic testing in patients who have hepatitis C, and there is a preference for amniocentesis over chorionic villus sampling, and you should avoid episiotomies and prolonged rupture of membranes in such patients. So I'm sorry, this is a busy slide, but the message is that if your patient was already on treatment for hepatitis C and she has received the treatment for 12 weeks or 24 weeks, but if she was exposed to ribavirin, this is a highly teratogenic drug. This should be brought to the knowledge of the patient. Of course, it cannot be given during pregnancy. So, just to make you and me aware of what we do, nowadays we give 12 weeks antiviral therapy to all patients of hepatitis C who are compensated, who have compensated liver disease, who do not have ascites or encephalopathy. 12 weeks is enough for most of the genotypes. But for decompensated patients, we use ribavirin in addition, and that is why we mentioned ribavirin. And most of the decompensated patients do not have pregnancy anyways. They are not fertile enough. Can we give, now this is a multi-dollar question, multi-billion dollar, because for hepatitis B you have prophylaxis antiviral medication in third trimester of pregnancy to cut MTCT. For hepatitis C you don't have anything. You raise your hands, हम कुछ नहीं कर सकते. I think that is quite discouraging. So now there are 3 papers which have successfully treated very small number of pregnant ladies, hepatitis C positive, in third trimester with usual antiviral medications, and they have reported no adverse outcomes, no teratogenic effects, and no adverse fetal outcomes. So maybe in few years of time you will see that this antiviral therapy is being used as anti-MTCT therapy also in cases of hepatitis C. So this is the same. Now, many a times we are called to do endoscopies, and endoscopy is a bread and butter for all of us, for all gastroenterologists. So we will welcome patients for endoscopies, but please remember, no endoscopies in first trimester unless it is a life-threatening emergency, bleeding patient or something else. For example, a patient comes to you with a foreign body impacted in the esophagus and is pregnant, has first trimester, still you will like to help the patient. So, but if there is GERD for which you are itching to do endoscopy, please postpone it to second or third trimester. So that is the message. If you can postpone, postpone it. Please make the procedure short, and for example, instead of colonoscopy, you can get the same information by doing flexible sigmoidoscopy. So as less burden on the patient as possible. Now, stabilizing patient prior to procedure is vital, and it should be performed by expert endoscopists in a hospital-based settings. There are a lot of endoscopists who are doing endoscopies in very small places, and for pregnant patients are likely to meet many accidents in such small places. My next slide will show you. So this is what is required. Please get an informed consent with clear explanation of a feto-maternal safety discuss all these issues with the patient before doing endoscopy. Documentation of fetal heart sounds prior to and post procedure is mandatory, medico-legally also, right? Otherwise the blame will come on the endoscopist or the hospital setting that during endoscopy procedure fetal damage has been done. Insist on intra-procedure fetal heart rate monitoring. Discuss with obstetrician as to what are the risks. Pulse oximetry, oxygen supplementation, electrocardiography monitoring is needed for the mother during the procedure. Now, the most important part is in second and third trimester, especially with twin pregnancies when they have huge abdomen. Don't ask the patient to lie down in supine position or prone position. Always it should be lateral position. Okay. Sometimes in ERCPs we ask our patient to become prone, and that can create disaster by pushing the patient to a state of shock because of IVC compression. Lots of patients who come with the pregnancy and portal hypertension. In my memory, most of my patients had extra hepatic portal venous obstruction and not cirrhotic portal hypertension. Okay, so they do very well because liver is normal, but you have problems with bleeding varices. Most of the time we are successful in managing these patients as we do manage our non-pregnant patients. But the incidence of variceal bleeding is increased in pregnancy. So if you know somebody who already has portal hypertension, ask her not to get pregnant, go to gastroenterologist, get an endoscopy done, eradicate varices, and then attempt pregnancy. Gallstones, very high risk. Otherwise also all females have higher incidence of gallstones, more vulnerable. Pregnancy increases it further more. 8% of pregnant women form new gallstones by the third trimester, and only 1% have symptoms. Okay, symptoms generally are right upper quadrant pain, and if a stone has slipped into common bile duct, it is cholangitis and jaundice. So this is not uncommon for us to receive a pregnant patient with choledocholithiasis and cholangitis. So what do we do? Normally we do ERCP. ERCP means radiation. We cannot expose the patient to radiation. So there are some other ways of tackling this problem. One, we should not aim at removing the stone. We can only leave a stent as a temporary therapy, which is a short-lived procedure. Secondly, if at all you have to bring out the stone or do something else, you can shield the abdomen with a coat. But problems are in plenty. Post-ERCP pancreatitis can occur, adverse maternal reactions can occur, and it has also been seen that prolonged endoscopies leads to adverse effects on baby also in terms of preterm labor, preeclampsia, fetal adverse like growth retardation, congenital malformation, low birth weight, or still birth. All of them can occur during prolonged procedures. So I think consent and monitoring are very important. I think we can skip this slide. Now the burning topic, IVF and hepatitis. So, where I practice, in my neighborhood, Dr. Kuldeep Jain also practices, and he sent me a patient whose husband was hepatitis B positive. The patient receiving IVF was not hepatitis B positive, and this was about a year back. On that day, I read the topic and got new knowledge. What to do when father is hepatitis B positive, mother is not. Is the risk same of getting hepatitis B for the fetus? So, hepatitis B is endemic. We in India, 2% of population may be positive, but I tell you, it is close to 7 to 8%. There are villages there is a village Gulavati near Muzaffarnagar, where 100% of population was hepatitis C positive.
Very common. Right?
Very common. So in our part of the city, it may be 2-3% or 4% in our socio-economic status, but otherwise it is extremely common. So hepatitis B is bound to get distributed in pregnant mothers. So the message is that hepatitis B itself does not adversely affect the pregnancy outcomes. So that is a very comfortable message. Even if mother is hepatitis B, the outcome is good on an average. But that may not be true for all the time. There is evidence that hepatitis B virus exists in ovarian tissue, in the ovum, in the follicular fluid around the ovum, and in the sperms. So even if father is positive, please remember the embryo is going to get infected with hepatitis B virus. So what happens subsequently is another thing. If the mother is carrying antibodies against hepatitis B, then the maternal antibodies, which can easily cross the placenta, will neutralize the hepatitis B virus present in the embryo. So my submission is, after reading all this literature, that we should identify non-vaccinated potential mothers. Ask them to wait for pregnancy, get them vaccinated, ensure that they have developed anti-HBsAg antibodies to the titer of 10 international units at least. So now there was one paper which I read day before yesterday that lot of, I don't know about, you are the best persons to know, a lot of corticosteroids are being used in IVF.
Yeah.
Particularly when you are not successful in one attempt or second attempt. So if you use corticosteroids in description, it says sometimes that 10 milligram dose more than 15 days, you should consider antiviral therapy. This is a very, very early kind of suggestion, but prolonged use of steroids in any situation can give rise to reactivation of hepatitis B virus in the mother. So this is what we have already discussed. Father HBsAg positive. I think with this, I must thank my all colleagues for the patient listening. Thank you.